Welcome, focused learners. If you're gearing up for your Clinical Research Coordinator certification, you probably have a little bit of that exam anxiety creeping in right about now. And honestly, you absolutely should. The ICH-GCP nuances on this test, which, by the way, stands for the International Council for Harmonization of Good Clinical Practice, basically the global ethical and scientific standard for trials, are notoriously tricky. But hey, you're in exactly the right place. Today's explainer is designed as a quick, gamified mini-course. We're going to rapid-fire through 10 high-yield questions directly inspired by the core exam material. I want you to grab a mental notepad and track your score out of 10 as we go. Let's see how exam-ready you truly are.
Okay, let's dive into this. We've structured today's session around 4 heavily tested domains. 1. Roles and responsibilities. 2. Documentation and ALCOA+. 3. The informed consent process. And finally, 4. Safety and protocol compliance.
Let's kick things off right away with Domain 1, Roles and Responsibilities. Get ready to lock in your answers for this first set of questions. Here we go.
Question 1. What is the primary responsibility of a clinical research coordinator in a clinical trial? Is it to make all medical decisions for study subjects? To manage the day-to-day operations and ensure protocol compliance? Or is it to obtain funding for the trial? I'll give you a beat to lock in your final answer.
Actually, hold your answer. I'm immediately firing off question 2 because these two completely go hand in hand. Under ICH-GCP guidelines, who retains ultimate responsibility for the conduct of a clinical trial at a site? Is it the CRC, the principal investigator, or the sponsor's medical monitor? Think about it. And this brilliantly illustrates the dynamic at the very heart of every research site. For question 1, the CRC's primary responsibility is managing the day-to-day trial operations and ensuring protocol compliance. But for question 2, the principal investigator, or PI, retains the ultimate accountability for all trial-related activities. See, the CRC manages the daily grind, but the PI holds the ultimate GCP responsibility. It's kind of like the PI is the captain of a ship. They can delegate steering to the crew, but if the ship hits an iceberg, the captain is the one answering to the authorities. That's exactly how the FDA views PI oversight. Even when they delegate tasks to highly qualified staff, the buck stops with them.
Let's keep this momentum going. Question 3. Which of the following tasks can a CRC typically perform when delegated by the PI? Can you, as a coordinator, make a final determination of subject eligibility? Can you obtain informed consent from subjects? Or can you officially diagnose adverse events?
The correct answer is obtain informed consent from subjects. Remember, making final eligibility calls and diagnosing adverse events require medical judgment. Those are non-delegable duties requiring an actual medical license. But as a CRC, you absolutely can obtain informed consent, with one massive caveat. You have to be properly trained, and your initials must be formally recorded on the site's delegation of authority log before you ever speak to that patient. In the real world, if an auditor finds a consent form signed by a coordinator who wasn't on that log, the entire patient's data could literally be thrown out.
Moving right along, let's jump into Domain 2, Documentation and ALCOA+. I cannot stress this enough. Documentation is heavily tested because it's consistently the #1 source of real-world FDA audit findings. So, question 4 targets the holy grail of GCP acronyms. ALCOA+. What does that very first A stand for? Is it accurate, attributable, available, or auditable? Lock in your guess.
So the crucial point here is that the A stands for attributable. Yes, data obviously needs to be accurate. But in the Alcoa Plus framework, the first A means every single data point must be traceable back to the exact specific individual who recorded it. Imagine an FDA auditor looking at a crucial blood pressure reading scribbled on a sticky note with no initials and no date. They can't verify who took it, if they were trained, or if they even work at the clinic. That completely compromises the integrity of the entire trial.
Let's test some more practical knowledge with question 5. We all make mistakes, right? But how you fix them is just as important as how you write them. When correcting an error in a paper source document, what is the correct procedure? Do you erase it? Use copious amounts of correction fluid to hide the evidence, rewrite the whole page, or do something else entirely?
Well, if you guessed correction fluid, oh boy, that is a massive audit trap. Never, ever use whiteout in clinical research. The exact GCP compliance sequence is to first draw a single line through the error so the original text remains completely legible. Second, write the correct data right next to it. Third, initial and date the change. And finally, state the reason for the change if it isn't completely obvious. That is the absolute gold standard for paper source corrections.
Next up, Domain 3, the informed consent process.
This area is absolutely critical for protecting patient rights. Question 6. Which of the following is considered a red flag during the informed consent process? Is it a red flag if the subject asks to take the form home to review, if they request a family member to be present, or if the subject signs the ICF without reading it or asking any questions?
It is a major red flag if a subject signs the informed consent form without reading it or asking questions. Now, you might be tempted to think of it as just a wonderfully fast, easy clinic visit, but you have to look deeper. Signing without reading strongly suggests a lack of understanding. It points to an inadequate consent process, and worst of all, it indicates potential coercion. As a CRC, you are the first line of defense in ensuring the subject actually comprehends the risks they're taking. It's not just a signature, folks. It is an ongoing ethical conversation.
All right, the final stretch. Domain 4, safety and protocol compliance. Let's finish strong here.
Question 7. What is the correct timeline for reporting a serious adverse event, or SAE, to the sponsor? Is it within 7 days, 24 hours, 48 hours, or 30 days of becoming aware?
24 hours. That is your high-yield golden rule number. Under ICH GCP requirements, SAEs must be reported to the sponsor within 24 hours of the site becoming aware of the event. Notice the wording there. Not 24 hours from when the event happened, but a ticking clock starting the exact second you or the site finds out about it. It's strict, it's non-negotiable, and missing it is a massive protocol violation. Moving to question 8. Which of the following would be considered a classic protocol deviation? A. Subject withdrawing consent. A CRA conducting a monitoring visit. The CRC entering data into the EDC. Or a study visit conducted outside the protocol-specified window.
The answer is a study visit conducted outside the protocol-specified window. Subjects always have the ethical right to withdraw, and monitors are supposed to visit. But missing that visit window is a direct departure from the protocol. Even if the patient just went on a surprise vacation and couldn't make it in time, it's a very common pitfall, and it absolutely must be meticulously documented and reported to the IRB as a deviation.
Question 9 is about careful oversight. What is the CRC's responsibility regarding temperature monitoring for investigational product, or IP, storage? Is it the pharmacist's job exclusively? Should you just ignore minor fluctuations?
Now, what's really interesting about this is that your job doesn't stop at simply writing down a number on a clipboard. As the CRC, you must ensure temperature logs are maintained, yes, but you also must actively document and quarantine the drug if there are excursions from the required range. Think about it. A broken fridge over the weekend could ruin millions of dollars of experimental drugs and put patient safety at severe risk. IP accountability is heavily scrutinized for exactly this reason.
We have made it to the final question to test your GCP mastery. Question 10. Which of the following is a massive red flag in study staff training? Is it having all staff complete GCP training, having complete training records, or staff performing trial-related tasks without documented training?
The ultimate red flag, and honestly one of the top audit traps out there, is staff performing tasks without documented training. It doesn't matter if you've drawn blood 1,000 times or done hundreds of EKGs. If that training isn't documented on the delegation log before you touch a patient, it creates severe compliance issues. All right, so tally up your score. How did you do out of 10? If a few of these GCP nuances tripped you up, hey, you aren't alone. To guarantee your success, you should definitely enroll in our full Udemy exam prep course for the Clinical Research Coordinator certification, where we break down hundreds of high-yield scenarios exactly like these. So I'll leave you with this question. If an FDA auditor walked into your clinic tomorrow morning, would your site's documentation actually survive the test?